Okay, I'm Barbara Stewart. Hi, everyone. It is a great pleasure to introduce my dear colleague, Dr. Sabrina Darrow. Dr. Darrow is an assistant professor and licensed psychologist in the Department of Psychiatry here. She is passionate about improving the link between research and mental health services with the goal of empowering individuals to reach their personal goals. She has a particular interest in helping youth struggling with depression, anxiety, and suicide. Dr. Darrow's expertise in clinical behavior analysis and her primary research interests include the clinical utility of assessments, mechanisms of action in psychotherapy, and implementation science. Yes, she does it all. In her role as, no, that was not in her actual bio that she gave me, I guess. In her role as the Associate Director of Research at the Young Adult and Family Center, she leads the evaluation and research program aimed at improving mental health services for youth and their families. Projects include evaluations of dialectical behavior therapy, cognitive behavioral therapy, intensive family therapy, and YAFC's telemedicine projects. Dr. Darrow is also leading the YAFC collaboration with San Francisco County's Child, Youth, and Family Systems of Care to implement and evaluate dialectical behavior therapy for adolescents in public mental health system. She is also a clinician with the DBT team for adolescents at the young adult adolescents and young adults, where she works with high-risk, multi-problem youth and their families, and she also supervises trainees' clinical work with youth. I won't get into all the other backgrounds. She is well-educated, well-credentialed, well-published. There are several pages here that you can look her up on UCSF profiles and read some of her seminal work. And she really is a true psychologist in all ways, has her arms and legs and mostly all of her head, her brain most days, in clinical service delivery, education and training, supervision, research, and community service. So it is a pleasure to have her here, and I'd like all of us to give her a warm hello. Hi.
Thank you so much. All right, I am going to jump right in since we're starting a little late and tell you about the research that I've been doing basically since 2015 in the child and adolescent services over at Langley Porter. So today's objectives, I'm going to talk about the gaps in knowledge that can be filled by effectiveness implementation research, talk about some principles I think are helpful when trying to build clinic-based research, and ways that technology can both facilitate these efforts and provide some challenges. Today, I'm not going to talk about how youth suicide, depression, and anxiety are problems. I'm assuming that everybody in this room knows that they are common, impairing. And I'm also not going to talk about psychotherapy efficacy. So we have some very well-established therapies for depression, anxiety, and suicide, cognitive behavior therapy, and one of the CBT's dialectical behavior therapy, and those are two that I will be talking about, but I'm not going to be talking about how they work. My focus today is really going to be on how we still have work to do to improve the delivery of these therapies in the real world. So disclosures, I don't have any conflicts of interest to disclose. The research that I'm presenting today is funded by the Young Adult and Family Center, which is directed by Dr. Kim Norman. I do have some funding from the UCSF RAP Digital Mental Health Award, along with Dr. Lauren Hack. And I'm a behaviorist, and if that'll become very clear. Can you mute them? No, just kidding.
We're having some technical things. It'll be a moment.
Just want to see the slides.
I can reenact them for you if you want. Do little like puppets.
I would appreciate that, Liz.
Yeah.
It's a good thing I ate.
full house. We turn on everybody. I have to take a picture for Sabrina. Like, it's pretty good for being remote viewing. Sometimes it's hard to do. Maybe not if you don't read anything. But
and there's no grand rounds next week.
For the sake of time, I'm going to keep talking while we problem solve getting my PowerPoint. But, so I was saying, I'm a behaviorist, and what that means is even without my PowerPoint, I can talk about the ABCs of behaviorism to apply to pretty much any problem at any time, even with like a fourth of my brain cells working. So to remind everybody, or behaviorism in brief, so behaviorism are really the core principles behind most of our evidence-based psychotherapies for depression, youth, and suicide. So the A stands for antecedent. So antecedents are the signals in our environment that signal a time when to do a certain behavior. And we can intervene on antecedents by either adding important reminders, such as your alarm clock that told you to get up this morning, and signals, time to get up. That's the behavior one in. Or we can also talk about stimulus control to try to decrease behavior, so decreasing the availability of stimuli that signal things that we want to stop. So, for example, when we're working on safety plans with suicidal individuals, we work on stimulus control by removing the means of doing the act and therefore decreasing the likelihood that the behavior is going to happen. The B, of course, stands for behaviorism. That's the middle term of our three-term contingency. And the very key to behaviorism and applying these principles is defining the active response that you either want to see more of or less of. So it might be getting up in the morning, it might be getting to school when you're working with an anxious kiddo. And really key is that you have some way of defining it so that you can track it and see as you're making changes with your intervention, is it actually working to decrease or increase a behavior? The final term of our three-term contingency is key, the consequences. So consequences from a behavioral perspective are thought to maintain a behavior. So they're what is going to either increase or decrease the probability of a behavior occurring again in the future. So the relief that I experienced from running out this door right now might be reinforcing of me escaping in mid-presentation because I no longer feel anxious. Same with a kiddo who's echo. That was so reinforcing. So I'll keep doing. All right. Wrapping or something? Oh, okay. Yes. But no, I can't see. Okay, so consequences are important. So those are our ABCs of behaviorism, and they're the principles that we use for evidence-based psychotherapies. And my next slide is going to tell you why I think behaviorism is really cool. All right. So when we talk about behaviorism, we often talk about how we're trying to understand behavior in context, and what we're talking about is understanding the antecedents and the consequences that are either signaling a behavior to occur or not to occur, and the consequences that are affecting the probability of it occurring again. So why do I think behaviorism is cool? One is that it's really this focus on the individual. So to really apply a behavioral principle as well, you have to understand each individual's context and all that means. It really encourages us not to pathologize. So rather than blaming individuals or looking for causes inside of individuals, we're looking for causes in the environment. And we're also really understanding that people do what they do because it works, right? So I'm leaving this presentation, even though long-term goals are to stay, give grand rounds, and educate everyone about behaviorism, because reinforcement, or the relief I get from running out, wins over my desire to work towards that long-term goals, right? So we can understand why people are doing what they're doing. And it also really encourages us to be for a strengths-based approach. So we're really looking for ways that we can build in and build environments that are supporting effective behavior in order to change behavior. And finally, what I think is really important and what really relates to what I'm talking about today is it encourages us to look at how we are part of the equation. So if we're saying that it's the antecedents and the consequences that are affecting how often behavior is occurring, then and we are part of giving signals about what behaviors we want and consequences for behaviors we either want to see more of or want to see less of, then we have to think about how we're part of the equation. And so I have this little graphic up, and you'll see it often. So we have this in our Intro to Behaviorism for our DBTers to remind them that to apply behavioral principles, you have to be a detective, because you have to watch for small changes and be ready to reinforce any improvements that you see. And also because you need to be, because behavior change takes time, and you have to be patient and watch for those patterns of behavior, not just instances of behavior. And so this is what I really kept in mind when I looked at the, where we're at with the state of psychotherapy and what we know, and how can I create an environment where I'm getting feedback and also able to support the kinds of behaviors that I want to see happening. All right, so taking a step back, let's talk about the types of psychotherapy research. So there are way back in the 90s, and then again in the early 2000s, they kind of revised this staged model of behavior therapy to give us an idea of what does it take to move a therapy from basic behaviorism, basic behavioral research, how do you move it out into the real world so people are using it in practice. And so the first stage is efficacy research, and this is what often people think about when they think about research. So this is where we're really prioritizing internal validity. So we're doing well-controlled studies, we're really thinking through what our inclusion and exclusion criteria are. So we're really defining like this, what problem we're trying to solve in a narrow sense, and controlling for other variables that may impact how well our treatment does. This is also where we're developing treatment manuals and really specifying what is the treatment that we are giving, and doing all sorts of things like adherence checks to make sure that people are really using the tool as it's meant to be used. And this is a very well-controlled test of whether or not that treatment works. After you've determined that a treatment works, then you want to know, well, how does it work in the real world? And this is what we refer to as effectiveness research. So this is where we're concerned with, well, will the treatment still work as well when you're doing it with patients in the real world that you're not screening, but they're just coming to your clinic? And with providers in the real world that haven't got the intensive training and focus on adherence that your research clinicians may have gotten. And then we also talk about dissemination and implementation research, cost effectiveness research, and all the other things that we really need to know for systems to have sustainable practices doing these empirically supported treatments. And so this stage-based model has really gotten us far, and we have lots of manuals and lots of treatments that we know that work. And we see this gap between the research and practice. So we, on the one side, where people are really focused on internal validity and inclusion criteria, then people are giving, here's a disorder and here's a manual for this disorder. And in the real world, we know that people come to us with lots of different problems that don't always fit neatly into the same boxes that were used to test the therapy. And so you see this gap where we have treatments that work and people aren't necessarily doing it. And so one of the problems that I think might exist, or more like a solution to this problem, and I'm not the only one that has thought about this, is to actually create a more tight system where you're more quickly getting feedback to researchers about what are the challenges that clinicians are running into and implementing these treatments. And that can inform the research, and then the research can feed back into the practice. And so it's with this idea that I set about to create an integrated program of research over at Langley Porter. And so here are some of the kind of key guidelines that I've used. So one is that I'm wanting to partner with clinicians with every step of the way. So I want to know about all of the decisions they're making throughout the time that they are doing a treatment. And I want to know about what the challenge that is they're facing and how can I let that guide my research questions as well as the data that I'm collecting. Corinne and colleagues outlined a few different methods to do what they talked about as hybrid effectiveness implementation research, with the idea that if you're using designs that are based in clinics and you're collecting data both on how well a treatment is working as well as the provider factors and systems factors that it takes to implement a treatment, that this is a way that you can more quickly move research findings into practice. So my interest has always really been in assessment. Part of that comes from being a behaviorist and seeing this intimate link between assessment and treatment. And also now from the literature that shows us that measurement-based care, so in implementing any kind of measurement really, I don't know about all kinds, but most kinds of measurement into services is a way to improve our outcomes. So if you are tracking and watching to see what you're doing and whether it's working, that actually will just improve your outcomes to begin with. So that's going to be the base of any clinic-based research is a measurement-based care model. And then I also have this assumption that clinicians want help. Part of it's informed because I'm a clinician myself and I know that we're making challenging decisions. But I think that what I really want is my research to be focused on clinical utility. So rather than this top-down, here's the thing I think you should be measuring, I want it to be guided by what are the decisions that you're making and how can I give you information to help you make those decisions better. All right, so what have we been doing? So I'll start with the dialectical behavior therapy clinic. So we started, well, and I shouldn't say we, but they started implementing dialectical behavior therapy for adolescents, so a family-based model of DBT in 2009-ish. Because it started out as a DBT-informed practice where we're implementing just the groups to begin with. But by the beginning of 2010, it was a comprehensive model of DBT. And that's what has the most empirical support. So comprehensive DBT includes weekly individual therapy, a weekly multifamily skills group. It includes a weekly team meeting for providers because providers working with suicidal and self-injuring adolescents need support. And it includes as needed family session, phone coaching, 24/7 for adolescents and every day for caregivers. And any teen participating has to participate with at least one caregiver who's coming to the skills group with them and who's also participating in family therapy. Something that's, I don't know that it's unique, but it's different about our DBT clinic is that we didn't cut off this family-based model of DBT at 18. So most of the data so far has been on the adolescent model for 18 and below, and then the adult model, which is a full year and doesn't require any caregivers to participate for 18 and above. There is some data now on using the adult model or a modified adult model with college-aged kids, and I think what I'm going to show you today is some of the first data that's using this family-based model with young adults. And so the young adults that come to our program have to participate with a caregiver as well. All right. So back in 2015, I was really stoked to be joining the DBT clinic because they were already doing research. It was amazing. It was like my dream come true, working in a clinic, doing an empirically supported treatment, and they're already collecting data. So they're using semi-structured diagnostic interviews at intake, The entry criteria into the clinic are similar to those in the randomized control trials. So teens and young adults have to have at least 3 borderline personality traits, have attempted suicide or have recurrent suicidal or self-injuring behavior. And we're collecting self-report measures of validated assessments of depression, suicide ideation at the beginning, a midpoint, and at the end of treatment, as well as some follow-up data. So, starting out, they're collecting these self-report instruments, but there has to be more data about other clinical decisions that we need to collect. So I had to set out to find out what those were. So here's an abbreviated conversation between myself and Esme Schaller, the director of our DBT clinic. So, how do you keep track of people on the wait list? This seemed like an important decision point, like how long are people staying on the wait list, and who's calling? On a Word document, I delete people when they are assigned. It's great to see the list getting shorter. Oh no, we need that data. What about who's in what group and when they start? So with a complex treatment with DBT, there's lots of moving parts, and when you're looking at the data, you want to know, what group did it matter whose group they were in? Did it matter what group they were with? They're a group effect. So, how are you keeping track of what group and when they start? Edme, I have this really pretty rainbow Excel file. Check it out. That is pretty, but colors aren't data. Well, I like the colors. Okay, so what did we learn at the end of this assessment? So this conversation really helped us identify where we had some overlapping goals, as well as where the research and clinical needs diverged. So it was very clear that we needed to make a tool so we could really collect this data and hopefully make Esme's job easier. Typing in a Word document, that's lots of finger strokes. And was there a way that we could retain that information, and so she wouldn't delete it, but she could still see the changes in the wait list, because that was really reinforcing for her to actually move people off the wait list and get them the treatment they needed. And it was also very clear that we had to keep the rainbow-colored Excel spreadsheet, which you can see a mock-up of here. So what we came up with was a tool in REDCap, which is a database management system that we have really available for research at UCSF. And we implemented this tool as a way to really keep track of all the decisions we're making about the course of somebody's treatment from the point of first contact when they're calling Esme to say they would like our services. All right, so let's dive into some of our data. So here are an overview of the youth who've been served by our clinic since 2010. So about 132 youth that are, the majority of which are European American, female, and heterosexual. This next graph I've been promising to myself and to the DBT clinicians, and so mostly this is just reinforcement for us, so I hope you enjoy. But this is a graph of how many of clients are entering our services each month since 2009 till now. And this is what it looks like compared to the clinician hours. And as you can see, it tracks pretty closely to the clinician hours available. We get more clinicians, we can see more clients, and that is a natural cap on what we can do. All right, but what about some of the outcomes? So how are we doing with providing DBT to these kiddos and their families? So as you would expect, one of the most important outcomes that we can look at is the number of suicide attempts. And so while the majority, 70% of the youth entering our program had one or more suicide attempts in their history, you can see we've had very few attempts during treatment, and so far none successful. This is looking at the suicide ideation questionnaire, so looking at significant changes. So we see that from the time they're beginning treatment until 6 months in, that there's significant decrease in the suicide ideation that they're reporting, and also significant differences between when they begin and graduation at post-treatment. Similar with depression scores, so this is the Beck Depression Inventory, so both the changes were significant at both of these time points. You can also see that there are large standard deviations. So let's see, like, how do these results compare to the efficacy trials that are out there? So one thing we can do to compare how we're doing with what's been done is by using benchmarking and looking at effect sizes. So effect sizes convert your findings to a standardized mean change score, and that allows you to compare across trials. It's what people use in meta-analyses. And another thing that's really important, so we'll look at depression, we'll look at changes in suicide ideation, and then we'll also look at treatment completion rates, because we know that it's really challenging to keep suicidal adolescents in treatment, that actually any suicidal clients are at very high risk for dropping out of treatment, which means they're not getting the skills that we think they need to stay safe. So the first two lines are the RCTs of the family-based model of DBT. So you can see that they are having medium to large effect sizes for both depression and suicide ideation, treatment completion rates in the mid-70s. Then the bottom two lines are our data. So the first is looking at 6 months. So the reason I broke it down like this is that the DBT trials for adolescents are really just providing DBT for 6 months. And then, but in practice, when people are not meeting criteria, we make the clinical decision to keep people in treatment until they are learning the skills and we see improvements in the behaviors that they set out to change. And so you can see that our effect sizes are not as good at 6 months, and then they're getting up to medium is maybe not quite large at graduation. You do expect that there is a drop-off in effect sizes when you move from doing well-controlled trials to trials in the real world. So this isn't too surprising, but let's look at some of our other data that might explain what's going on. So one way that I really like to look at data is to go beyond looking at statistical significance and really see if there are ways of looking at the clinical significance. So there are two ways, or two pieces of looking at clinical significance. So the first is looking at whether or not a change indicates that somebody has moved from a dysfunctional distribution to a functional distribution. So are their scores now more likely to just be in that normal curve for somebody that's not experiencing depression versus the curve that you would expect for people that were experiencing depression? We also can look at reliable change. So people's scores can change over time for a lot of different reasons, but did they change enough that we actually think it's a real change that reflects real differences in their life? And so we do this by calculating a reliable change index, which is based on population data using those same measures. I'm happy to chat more about how I did this offline. And so then you can take those two criteria, so whether or not somebody had clinical significant change or reliable change, and you can categorize them. So we'd consider someone recovered if they moved from the clinical significant range, so they were above the cutoff on the Beck Depression Inventory and they moved below the cutoff, and that change was big enough to be reliable. So they weren't just like a point above the cutoff and they moved to a point below. So it's something that we actually can trust. We consider them recovered. Improved, on the other hand, they're still going to be above that cutoff, but they had a reliable change, so a significant change that we think probably matches up with how things are working in real life. So here's what our data look like, just looking at 6 months. So you can see that while we do have people that are recovered based on their scores on the Beck Depression Inventory, that's not true for the SIQ. So that kind of supports keeping people in treatment longer, right? If the data that they're giving us are showing that they haven't made reliable, significant change, then we probably want to change something up about what we're doing, and we don't want to just say like, okay, be done. This other part of the graph shows you some of the reason why our data might be different from the randomized control trials. So the deteriorated and not a problem, those two categories, those are problematic. We want to know what's going on there, but those people likely didn't make it into randomized control trials because it means that they started off in the functional range. So they were below cutoff for on the SIQ or the BDI. So they weren't actually showing that problem when they started treatment. And then let's look at that at graduation. So you can see things did shift over, and we now have some people that are showing improvement on that, or that they're recovered on the SIQ, as well as more people are recovered on the depression inventory, and we definitely still have more work to do. All right. So what else can we learn from our REDCap data and the other decisions that we've been making about using DBT in the real world? So one of the things I think is really important is the timing of treatment entry. So in both the randomized control trials, they had inclusion criteria that were about how recently somebody had either self-harmed or attempted suicide. For the Macaulay, they had to have the most recent suicide attempt in the past 4 months. For the Mellom trial, they had to have recurrent self-injury, and that the most recent had to have been within the last 16 weeks. Side note, I'm not showing any self-harm data. It's not that we don't have it, it's just that we only have collected it with diary cards so far. So, and that was too cumbersome to show you. But it is also another a problem in really comparing what we're doing to the RCTs. So timing of treatment. When do people get into our services? So our wait list length ranges from 5 to 623 days. So there's people, this suggests that people really are not getting in right when they need it, and not getting in when they're, we might expect that they're most at risk and maybe most willing and motivated to engage in an intensive treatment like DBT. 623 days, you're like, you guys, what are you doing? This is so long. What happens with some of these outliers is that they are on our wait list, they can't stay safe in their home environment, and they end up going to residential. Some have gone to residential and a couple times, and that's why those are so long. So we're keeping track of this, keeping them at the same place in our waitlist data in the REDCap tool, so that when they do come back, we can help prioritize getting them in. And as you saw from my graph that I found really reinforcing to look at, there are real world limits on how we can get people into treatment based partly based on clinician time. What about the length of treatment? So I've already talked a little bit about how we make decisions to keep people in treatment. That doesn't happen when you're doing randomized control trials. So in fact, only 13% of our clients graduate after 6 months, so after going through the skills modules just once. And our average treatment length is more like 9.3. So most people are getting a few more skills modules. Another interesting thing is that 56% end up staying with us and doing some other behavior therapy afterwards, whether it's prolonged exposure for PTSD or behavioral activation, for example. So they're continuing to get treatment. When you look at the follow-up from the randomized control trials, this is in line with some of that data. So the Mellom and colleagues just published a 3-year follow-up, and they showed that up to 50% of the people who got DBT continued to get some form of treatment at some point afterwards. So here's this real-world question: is what is the treatment length that we should expect for people who are engaging in DBT, where we can prioritize individuals' needs over the needs of doing a well-controlled trial? And how can we bring in some more data that help us inform these decisions of how long we should suggest that families are staying in treatment and engaging in this intensive service? Another thing that I think is really interesting to think about is what happens to those who discontinue treatment. So as we said, it's really important to get teens to complete the whole treatment, and there are high rates of dropout, although lower in DBT. Interestingly enough, about 23% of people who dropped out, went to residential, came back to our clinic. And I think that this really speaks to the culture that we have on the DBT team, and that starts with the first touch that that all families have when they are referred to our clinic, when they have the initial phone call with Esme. So Esme has been reluctant to give this job of intake referrals to anybody else because of what she does. And so we've been tracking how much time she spends with families. And on average, she's spending at least 13 minutes. So this isn't just gathering information, but it's providing hope, it's providing resources, and it's providing referrals. And her calls, as you see, range from 1 to 41 minutes. I put a million asterisks because I think 1 is probably an outlier that I didn't get rid of. And I also did get rid of some of very large outliers that I imagine happened because a button didn't get pressed. And I might not be right because I didn't check that with her yet. All right, so one thing that we think about as a DBT provider is how to keep people engaged. And so what are some of the things that we can look at as far as engagement, and thinking about how our program is unique and we're bringing in young adults, not just teens, and expecting them to engage with their caregivers. Like, are there differences in engagement, and what does that mean? So in fact, when we looked at the data, there aren't significant differences in outcomes between teens and young adults. But let's talk about, so engagement you can look at from a number of different ways, but 2 that I was going to share with you today are the number of skills modules. Luckily we have our RedCap tool, so we have that data available. And then I was also interested in the number of family sessions, since this is one of the biggest differences between the adult and the family-based model. So we have to take a little side trip here and talk about my adventures with Epic/Apex. So when I was implementing this research protocol and really trying to gather all this data, I was like, oh great, it's July 2015, and we started using Apex Epic over at Langley Porter. So this should be perfect. It's an electronic medical record. It's technology. It facilitates data collection, and I should just be able to go run a report and tell you how many family sessions our DBT clinicians have been doing with each of the families. And I worked with the people to create the report, and it turns out it's not so easy. So one of the problems is that Epic wasn't built in a way that matches our organizational structure. Our organizational structure has also shifted in the time in which Epic was implemented until now. And so it wasn't easy to just run a search on the DBT Clinic, even by picking by providers. It was pulling more than just any encounter, including telephone calls and other notes that I couldn't actually figure out what they were. So scratched that idea and went back to our tried and true method of chart review. And wrangled Lauren Gonzalez, a postdoc who is here, Jonathan Reeves, a Cal student who's been working with me, Thomas Tolfsen, and Julia Geit, who are visiting scholars that have been working with me, to review both the paper charts going back to 2010, as well as the electronic charts. Luckily, we use this survey tool called Qualtrics to capture the data, so we didn't have to go from paper to electronic, so we got rid of that step, but it took a lot of work, and I can now show you the number of family sessions. So as you can see, in general, teens are participating in more modules before they graduate than young adults, which is interesting because usually young adults are given the adult model, which is a full year. On the other hand, the young adults are participating in fewer family sessions. But you can also see that there's a lot of differences, and diving into the data and trying to figure out how these decisions are made, I think it's probably not based on age range, and how we can really inform our decisions going forward as far as how often to have family sessions and how many modules people take to graduate are really pressing questions to inform doing DBT in the real world. All right, so our new protocol that I've been working on this last year, one of my goals was to do less chart review because that's not sustainable. But that requires asking more of providers. So I had to think really carefully about what I'm asking them to do with their limited time, because as enthusiastic as they are in helping me out, there are real world constraints to their time. So in asking them to do more, I decided I really needed to make it as easy as possible, so as few clicks, showing up on in their inbox at a time that's going to make it easy to do. So it comes Wednesday mornings right before we have our meeting, so in case any questions come up, they can ask me then, and hopefully still complete it. And even though this is in line with our values of collecting data, and this is what we, these values that we all share, which are sources of reinforcement, those are very long term. So I figured that we needed to add some short-term reinforcement in there as well. So here's an example of the emails that they get sent. This is me when you complete your weekly report consistently. And Ashley replying that have A+ gift work, and apparently it's working because they've gotten 100% completion rate so far. All right, so moving on to how we've expanded this to the other services that we provide for mood and anxiety disorders. So I can't take credit for integrating the DBT Clinic with the DBT providers way back in like 2013 or before. People just decided that the CBT providers that were lone wolves in the department should come together and live with the other behavior therapists, because CBT, DBT, all based on the ABCs. All right, so I'm working on that one. Okay. It makes sense because we have this shared expertise. And some of us might be more experts in working with suicidal individuals. Some might be more experts in doing exposure and response prevention with OCD, and that this would really benefit all of us, as well as provide support, as we know is important. We also know, as we've been talking about some, that there's overlap in treatment trajectories. So DBT clients end up needing CBT. So when they're done doing the intensive treatment, they're sticking in, getting more behavior therapy. And then what I haven't done a great job of tracking, but it's there in my data somewhere and going to be better tracked going forward, is that some CBTers end up becoming DBTers. So people, when they're presenting, may not disclose a history of self-harm. They may become suicidal at some point in their treatment and end up needing an intensive level of care. And so it makes sense to house all of these treatments together. And then from a research perspective, it also makes sense, given that we see high rates of comorbidity, especially among anxiety and mood disorders, in treatment-seeking populations. All right, so the growth of CBT services. So I don't think I convinced Esme to use REDCap fully in 2016, so this may not be representative of how many CBT clients we were seeing at that time, but definitely by 2017 we were using the REDCap tool to track our referrals. And as you can see, the referrals have really increased by a lot, and this is the projected rate for this year. If we keep getting referrals at the same rate, we'll definitely keep going. We'll still keep growing. So why are youth seeking treatment? So this is based on what people are saying at the time of referral. So this isn't based on any diagnostic evaluation. Some of it is provider referrals, some of it is parents calling, some of it are the youth, and this is what they're reporting. So about 43% are reporting struggles with depression, about 64% with anxiety, and about 24% with both. And then breaking down anxiety a little bit more, we see that social anxiety, as you would expect in a treatment-seeking population with this age group, is the highest. Generalized anxiety is the next, which is a little surprising. I think GAD and OCD, high impairment, so it does make sense that they would be seeking treatment. GAD, age of onset is usually quite late. Where mean age is 30. So I wonder how this matches up to the diagnostic interviews that are done once people get in. Haven't looked at that. All right, so then I was trying to think, how are we going to do a research protocol given that we have such a wide variety of presentations, that this, I don't want to overload with clinicians with a protocol per disorder, because that would be creating this gap that I'm trying to not do. I don't want to dictate the length of treatment, because it's going to make sense for people to have different lengths of treatment based on what they're struggling with. I also wanted to allow for providers to have to use the assessments differently. So we're talking about a research protocol to do measurement-based care, so to implement self-report measures with the youth. So some providers prefer that their clients do it outside of their office, some will integrate it into their session, and all of the options in between. And I also really wanted to make the assessments result easy to use. Again, collecting data is in alignment with our values. We know it improves services. We are all agreeing that we want to contribute data to the research. And we have real constraints, so we need to build in some short-term reinforcers. So if that data is easy to use, hopefully that's a reinforcer. So what I came up with was a flexible protocol that we implement electronically. So we're basing it on weeks rather than sessions, since we have variable length of time. And I'm also asking the clinicians to input the number of sessions they've had each time they're giving the survey, giving that Epic sucks for pulling the data. I'm also only giving them 2 surveys. So one survey that everybody uses when people start, and then another that's used ongoing. And then there are optional ones. There are optional assessments. So within each survey, there are multiple assessments. Some are given to everybody, some are optional, and some happen based on algorithms because people meet criteria for likely have social anxiety disorder on one measure, and so they'll give a more focused measure that gets at avoidance avoidance behaviors and fear responses if they meet those criteria. Plus, we give them optional ones. So the Tracking Therapeutic Alliance is something that you do that we have integrated in those surveys, and often people want to do something like that more often, so they can do that if they want. The electronic surveys, and they have lots of links. Oh man. Okay, running out of time. So lots of links, so you can put the link on your desktop, you can use it on a tablet. The YAFC was generous enough to buy tablets that we can use to give these measures. If clinicians have consent, they can email the links to their kiddos, so lots of ways of doing it. And they automatically get an email report, so as soon as the kiddo finishes the assessments, email shows up, copy and paste it into your notes, super easy, and also into a tracking sheet so you can see graphs over time. So I, of course, being the good behaviorist, I had to establish the clear guidelines. So we had these conversations, partnering with the clinicians, and I wrote up this really nice, detailed protocol, step by step, how you do everything, how you get the links on your desktop. And you might see the problem. Our protocol was implemented here when there was only 4 of us having the discussion, and now we have many more, which is not a problem, but it is a problem for looking at a wordy Word document. And so I've been working with Yaran, one of our visiting scholars, on creating a flowchart that will be better stimulus control for implementing the protocols. I'm gonna maybe skip this, so we're talking really quickly. Seeing how we should expand our services. Should we do more breadth for more age ranges or more depth? There's been a sense that there's really this need for more school-age children, and if you see, here's ages in 2017 of referrals, 2018, 2019, it certainly looks like the demand has increased, so it fits with the experience. But if you look at overall, we still do see this almost a normal curve, but it fits with this idea that treatment seeking for anxiety usually drops off around 11 or 12 and then increases mid-teens. That depression doesn't start until mid-teens, so it still does seem like the bulk of our services should focus on this mid-teen age range. Barbara, validated. Okay, there are lots of challenges. I've been talking about many of them. There's so many changes, so keeping up with them, balancing research and clinical priorities. Tech support, I've learned way more about tablets than I ever thought I would or that I wanted. There's lots of data coming out now that's talking about how when we're trying to boost our services using innovative technologies and apps and things that we need somebody there that keeps up with that, and that is definitely consistent with my experience. Funding, I won't even talk about. So applying the ABCs to team science, I don't have time. I read this article and I felt very validated. So this was some research, qualitative research, asking people who do team science and dissemination and implementation what it takes. And this is what they came up with, and it fits so nicely into my ABCs. So developing and maintaining clear expectations, promoting and modeling effective communication, and establishing shared goals and a mission. So there are shared values, or in other words, reinforcers. Also, relationships are key. Lots of reinforcement, including the laughter that I heard earlier, for all these efforts. And I'd like to thank everybody who have reinforced my efforts along the way.